Hi, everyone. I'm Greg Kurt, Vice Dean for Research. We're going to give it a couple of minutes. I see Sarah, once again, you are populated on everyone's as the name for almost everyone. So Vanya, Sean is now changed.
Was going to say, I
Um,
think it's the speakers.
yeah, this didn't happen before. I don't know. Something's changed with the Zoom settings or something because this happened last time too.
Yeah, we'll fix that.
Yeah. And I'm looking for Gordon.
Yep, I'm
Oh,
here.
What? Oh,
all right.
Am
Again,
I
it comes up as Sarah. That's
okay.
why
I'm
I
attending a
didn't
call.
recognize. All right.
am I here? Is it,
We don't see you, Gordon. We see Sarah Tabinski, but oh, there we go.
good,
Yes.
that's a better. Yep.
You can try to go in and click the little three buttons at the top and change your name, but it's okay if
What does it say?
you don't want to bother.
Oh, what does my name say? It should say Gordon Smith, shouldn't
It should, but it doesn't this time. I think the speaker link was populated by Sarah, and it sort of gives her credit for everything.
it? Oh, so how
Also,
do I?
Greg, can we ask folks if they are at JHU or at that they put their institutional initials behind their name so we know?
And that would be that's a great idea. We are going to ask. Actually, why don't I go ahead and jump in and do some framing? Because the intent of this is to facilitate some collaboration. So we're actually going to use a Google Drive, Vanya, to ask people to put in who they are, where they're from, and a little bit about what they're interested in as it might relate to rural health and substance use. So we're going to try to collect that information. Actually, looks
So
like
how can I put my, so my name doesn't even show up? Is that right?
it's okay, Gordon. We'll introduce you, and I don't think we can change it. It's okay.
Because
Um,
normally it does when I do normally Zoom, but I guess it's because you've set it all up. Yep.
yeah, we set it up, and it's just missing. So again, I'm Greg Kirk, Vice Dean of Research, who, along with Vanya, who just spoke up, we started the Rural Health Initiative a while back with the real intent to grow the Hopkins School of Public Health focus, insight, and to grow some expertise because although we're engaged in Baltimore and many places around the world, our emphasis on rural health topics has been more limited. Um, as many of you know, and as Junie will drop into the chat, there is now a partnership between Johns Hopkins and West Virginia for pilot project grants. There's announcements from both sides, and there will be more specific sort of application instructions that we anticipate to be shared in a couple of weeks. But essentially, there's $150,000 pilot grants where there needs to be a paired collaboration with a co-PI situation between one from Hopkins and one from West Virginia. And it can be on any topic. We sort of were anticipating and developing this in with a focus on rural health. That doesn't necessarily have to be the requirements, although it is a primary emphasis of the calls for these opportunities. So I think if we could also, you guys could click onto the Google sheet that Junie shared in the chat. What we'd like to do is to have people fill those out. And what we've done in the past was just to have people drop their names in the chat, but we had over 150 or so registrants for this, and the chat would get pretty congested. So we thought it might be easier to navigate. Gosh, this is getting filled up pretty quickly. I'm not sure how many people we have on. A lot of times, the number of people who actually sign up and register for talks don't actually always make it. But I think this would be helpful. And again, Junie, we'll have to drop that in periodically because as people join, they wouldn't be able to see it in the earlier chat. So, our plan for today is to have speakers from both institutions. They'll each give about 20 minutes each to share some of their own individual and team related work on rural health and substance use. I'll introduce them in just a second. Then we'll have another 20 minutes for questions from the audience. And then we're going to leave the Zoom on, and we will try to, as best we can in the next 30 minutes, to give individuals the opportunity to sort of raise their hand and share, like, I'm interested in this idea for one of these collaborative projects, and just sort of facilitate some making connections between our two institutions. So I think there's a really good mix. I'm seeing a lot of both JHU and WVU after names. So I think it's encouraging that we've already been able to connect at least to this degree. This is the first of a series of 3 of these conversations. Junie also will put the links in the email. Thank you, Junie. Junie Burke and Sarah Tabinski with our research office have really helped to coordinate these. We'll drop those in. So in the coming couple of weeks, there's another one that will focus on social prescribing as a response to social determinants of health, again with the rural health focus. And then another one within a week or so after that, that's going to talk about, it's going to use a research study from West Virginia that's looking at cardiovascular health in pregnant women as an introduction to different research platforms, including the research the research site that Hopkins leads in Hagerstown, Maryland, as well as some practice-based and clinical research networks from West Virginia. So again, it's really focusing on sort of research platforms where projects could be carried out with a case study overlaid on that, focusing on cardiovascular health and pregnancy. And again, Junie's going to put those in, and we again will do the same registration, as well as for people interested. The Zoom will extend an extra 30 minutes after the seminar in order to allow people to try to make some connections. And it's not that we're expecting everyone to solidify a grant opportunity. This is really to find people who may have some similar ideas that you can connect separately. So let's turn to today's panelists. We're very privileged and eager to hear from both Sean Allen and Gordon Smith. Sean's going to speak first. He's an associate professor in health behavior and society. He's got an endowed Bloomberg Bahi, the Bloomberg American Health Initiative professorship role, and he's been working in varied settings, including amongst indigenous populations, rural populations in Oklahoma and West Virginia. His work really focuses on addiction, overdose, harm reduction, incorporates policy and prevention issues, targeting and assisting people who use drugs. And again, he's particularly paid attention to rural communities throughout his research career. He leads a NIDA-funded cohort looking at HIV risk among people who inject drugs in West Virginia, and he's going to share some of the data from West Virginia with us today. After that will be Gordon Smith. Gordon is a distinguished professor in the School of Public Health at West Virginia. He's actually spent a fair amount of time in Baltimore, including studying overdose and trauma at the University of Maryland Shock Trauma Center. He's worked in multiple settings, building out injury-focused work to examine causes of drug-related deaths, drug-related infections, and other complications. He's looking at preventable causes of drug overdose and part of a national rural health consortium. And he's going to share with us some of his data from West Virginia about why overdose appears to be more fatal in West Virginia, including some mapping of overdose locations and how counties are responding to overdose. So with that, Junie also can drop in a little bit more information on the speaker backgrounds, but I want to turn it over to Sean to get us started. And I think, Sean, you're just going to share your slides. Great.
Okay. Hi, everyone, and thank you, Greg, for that introduction. Today, I will be talking about some of our research in West Virginia related to population estimation methodologies. I'll also briefly talk about some of the ongoing work that we have for the cohort study. So first, let's start with a little bit about me. I know Greg just read a lot about my bio, but I did want to highlight that my research really broadly focuses on the implementation of harm reduction approaches, and that includes syringe services programs as well as public health vending machines. As Greg mentioned, I currently lead a cohort study in West Virginia that examines how law enforcement practices, drug treatment, and harm reduction sort of coalesce to shape HIV risks. And we'll talk more about that later. I also lead a study that explores the attitudes and beliefs that the public health and healthcare workforce has about traditional medicines, Western medicine, and harm reduction. And last but not least, I do like to sometimes summarize my career with the phrase drugs and bugs. So before entering public health, I studied entomology at the University of Kentucky, where I very briefly conducted research on bed bugs. And I'll tell you, it wasn't for me. So here I am today studying drugs. So before I begin, I just want to share a little bit more about where I come from. So I grew up in Clay County in southeastern Kentucky, which is deeply rural and has been very disproportionately affected by the addiction and overdose crisis. So Manchester, the county seat where I grew up, adopted the name City of Hope as a statement of resilience and a commitment to change. Clay County is also known affectionately as the land of swinging bridges, although crossing some of them requires more courage than the name might suggest. And I share all this because the places that raise us have a way of staying with us, and they shape what we notice, what we carry, and how we understand the lives of others. So you may occasionally hear my Appalachian accent come through, but more importantly, I just want to be transparent about the perspective that I bring to this work. So now to the main event. So the scale of the addiction and overdose crisis has left many rural communities trying to meet profound needs with very little resources and often very incomplete information. So very few communities have current estimates of how many people inject drugs or a clear understanding of the circumstances shaping their health and service needs. And without these data, programs are often built around best guesses rather than local realities. So population estimation studies, those offer a way for moving forward and helping communities better understand who needs services, where the gaps exist, and how limited resources can be directed with greater precision and purpose. For this study, we use the capture and recapture population estimation, also sometimes called the CRC method. This method has been widely used in public health, including among people who inject drugs, sex workers, and refugee populations. And for us, we were trying to estimate, again, the number of people who inject drugs. So direct applications of this method involve two periods of data collection, some obviously called the capture and then later the recapture phase. So during these two phases, you survey members of your target population and then measure the degree of overlap between the two phases. In other words, you ask people if they previously participated in your study, and those people who said yes are considered recaptured. You can then use the count data for each study phase along with the number of recaptures to calculate a population size estimate. Today, I won't be talking a lot about the mathematics underpinning the methodology or its assumptions, but please reach out if you're interested. Happy to talk more about that. So while this method has been widely used in public health, it's mostly been used in urban areas. And there's very little research that talks about how or even if this method can be used in rural communities where populations, you have a significantly lower population density. And all this really becomes a problem when we think about the scale of substance use harms in rural communities. So our primary goal for this study was to figure out if this method can be successfully applied in rural areas to calculate how many people there are that inject drugs. And if successful, we also aim to develop a toolkit that other rural communities could use to inform their own population estimation studies. We conducted the study in Cabell County, West Virginia, which is located along the state's western edge and borders Kentucky and Ohio. Cabell County is home to around 77,000 adults and includes the city of Huntington. However, almost all of its physical land space is considered rural by the U.S. Census Bureau. And Cabell County also has a substantial burden of heroin-related overdose fatalities and was identified as vulnerable to HIV and viral hepatitis transmission. For this study, we partnered with the Cabell-Huntington Health Department. The Cabell-Huntington Health Department serves both Cabell County residents as well as people in the city of Huntington. And from 2015 to 2025, the Cabell-Huntington Health Department operated a harm reduction program that provided a great number of services to people who inject drugs. And we'll talk more about this program in a moment. In terms of data collection, we knew that people who inject drugs are already heavily stigmatized for their drug use, and they might be reluctant to participate in our study if we required them to disclose their drug use up front. So we set very broad inclusion criteria to be at least 18 years old and to have ever used drugs of any form by any route of administration. And all data were collected anonymously, and our survey included measures related to substance use, service access, and risk behaviors. So the capture phase occurred in June of 2018 at the Cabell-Huntington Harm Reduction Program and lasted approximately 2 weeks. People who presented to the program were approached by study staff and invited to participate, and all participants received a very bright green bag filled with snacks as an incentive for their participation. And we selected this bright green bag as an incentive because we wanted to make it memorable. So if we think back to the capture-recapture method, we have to be able to accurately determine if people previously participated. So in this case, we asked them, hey, did you previously participate and did you get that bright green bag filled with snacks? So it's very easy for people to recall whether or not they'd engaged. The recapture phase, the second phase of data collection, that focused on recruiting people who inject drugs from community locations. So we identified those through discussions with local community members, as well as a series of geospatial analyses of indicators of potential drug use, so things like crime, and overdose, discarded syringes, things like that. We also gave people a $10 grocery gift card as an incentive. So in terms of data, in total, we had 797 surveys that were completed. Of these, 529 reflected people who reported having ever injected drugs in their lifetime, and 395 reflected people who had injected drugs at least once in the past 6 months. And that recent injection drug use really became the focus of our analyses. So I included this graph of cumulative data collection by day to illustrate a very simple lesson. Research in rural communities is absolutely possible, and you should know that it moves at the speed of relationships. So our study staff, we collaborated with the local health department, which was already trusted by the population. Really piggybacking on that trust, it was very easy to collect a very large volume of data collection, over the course of 3 weeks. Among the 395 surveys that indicated recent injection drug use, 21 were recaptures, or people who had participated more than once. And so using these data, we estimated that there were 1,857 people who had recently injected drugs in Cabell County, and that translated to about a 2.4% population prevalence of recent injection drug use at the county level. At a population level, most people who injected drugs in Cabell County reported being white. They were less than 40, single, and unemployed. 28% reporting having never completed high school, and 64% reported going to bed hungry at least once per week. Average age of first injection was just under 25 years of age, and on average, people reported injecting 4.5 times per day. And drugs most commonly injected in the past 6 months were heroin, followed by methamphetamine and fentanyl. Large proportions also reported having reused injection equipment they knew had been used by somebody else, and nearly 3 in 4 reported having attempted to quit using drugs in the last 6 months. Now, I want you all to know that we know how to do more than just count. So we used all the data. It was more than, our purpose was more than just counting people. We went on to use the data to publish more than a dozen manuscripts on topics such as HIV testing, injection initiation, injection socialization behaviors, polysubstance use, as well as access to sterile injection equipment. And all of these data, they also served as preliminary data for our current cohort study in Cabell County. So when we wrote that study, it became very easy to make the case that we had enough data to justify the existing cohort, because at that point we published more than a dozen manuscripts and we had a very strong understanding of the epidemiology of injection drug use in Cabell County. So in terms of dissemination, after we conducted the study, we wrote a population estimation toolkit. Now, I admit when we first developed this toolkit, I was very skeptical. I wasn't sure if people would actually use it. But overall, we've had a great response, and we've heard from a lot of people who've gone on to plan their own population estimation studies. And there is a link at the bottom of this slide. Please check it out. There's a lot of great material there. The toolkit walks people through what we know about the addiction and overdose crisis, as well as the lessons that we learned doing our own study, such as how we collected data, how we figured out where to go, incentives, stigma, everything like that. We also incorporated the perspectives of our collaborators, so we wanted to highlight them as they were not only essential for the success of the project, but they were also leading efforts at the local level in terms of response. So this is an image of Dr. Michael Kilkenny, who's the physician director at the Cabell Huntington Health Department. He's also been a co-author on all of our resulting manuscripts. After we developed the toolkit, we also wanted to demonstrate how the population estimation study data can be used to estimate service needs. So we developed this online tool where you can input hypothetical parameters surrounding your own study, and it will output the volume of services that the population might need. So for example, you can input how many syringes people might need per day, as well as naloxone kits needed annually. And so you can also read about this study in the American Journal of Public Health. And again, it did go on to directly inform our current cohort study. And we're following 400 people over the course of 24 months. And we're looking at how law enforcement, drug treatment, and harm reduction shape HIV transmission risk. We also have gonorrhea, chlamydia, syphilis, Hep C, and HIV testing as part of the cohort. So again, this is a very powerful methodology that can really set you up for success for later studies. So in closing, I just wanted to highlight a few lessons learned. So collaboration is not simply a strategy, it's the foundation for meaningful partnerships and lasting public health action. All of my studies are really anchored at the community level. So just know that it's always a good idea to involve the community whenever you can. Form a research council, form an advisory board, involve the locals. Also, strong collaborations require trust, transparency, and shared decision making. This is especially true in rural communities where there is a lot of justifiable mistrust of outsiders as well as research. And third point, effective public health research begins by listening. I think that probably is the most important bullet point on this slide. As outsiders, you might think like, oh, I'm an expert in addiction and overdose, and you go into a community and you start talking to somebody who's lived there for 60 years. They're absolutely the expert in the room, because those local community members, they understand the history, the relationships, as well as the challenges that shape local health, and just never discount that local wisdom. It should really be at the forefront of all your studies. And I know this, the purpose of this seminar is also about, helping establish new collaborations. So I would just add this, that trust is not built through one meeting or one grant. You're really going to have to invest in those collaborations and go visit. As someone from a hometown, I don't know that I ever met someone who was doing research in my community. They were always, behind a screen or, um, never really there as their data collectors were present. And last but not least, involve community members in dissemination activities and publications. That just is the right thing to do. So I know we're talking about collaboration, so I'm going to do a little bit of shameless self-promotion here. Here's the list of topics that I'm interested in. Please reach out if you want to brainstorm topics or ideas or just hear more about my opinion on whatever you're dreaming up. Happy to share that. So with that, here's my email address. Reach out with any questions, comments, concerns. Happy to talk more. I think I'm on time, so I will kick it back to Greg.
Thanks very much, John. Excellent introduction and important take-home points. I think it's very vital that we're reminded that engaging with the community is important. These are small pilot project grants that we hope will grow into something larger. So I want to reinforce Sean's list of things to do and things to avoid as we envision these partnerships to grow. And I think at an institutional level, we want to view these not as one-time, one-off types of collaborations, but to build something that's more long-standing and more substantive. It's nice to get a small pot of money to get things started, but the things that we want to do and the things that we want to impact take time. And with that, we will have time for questions for Sean, but we're going to go to Gordon Smith to hear about his work, also centered in West Virginia, and then we'll do questions after that. Gordon, go ahead and share your screen. Take it away. We see the presenter mode, Gordon. I don't know if you want to change the display settings up at the top.
You
Yeah.
are on mute, Gordon.
If you go up there at the top where it says display settings, you should be able to click on that, and I think it says something like switch the screen.
Oh,
There we
yeah.
Oh, no, that we jumped
Slideshow.
off your slides there.
So is it not on the right setting still, is it? What do I need to do?
If you go up to on your screen, it says on the presentation mode screen, it says display settings.
Oh, I can't see.
If you go
It
up to the top of that,
It just goes to a full screen for some reason.
but if you look on your presentation mode screen, it's not that one.
The
They make it
slideshow,
complicated.
the presentation mode, which is, can you see my screen at the moment?
We see all the slides
Yeah,
right
that's
now.
right. Custom slideshow. Whereabouts is the presentation mode then for this?
You got to be in the presentation mode and then you can switch the screen. That's the way I navigate it. I don't know if others have suggestions.
Because when I do slideshow,
Yeah, I can help, and I'm going to draw on your screen when you go to slideshow again.
yep,
Click here. There's an
You
arrow
know-
down here. Yeah.
apply to all. Oh, that one. Yep.
Yep. And then once it goes,
There we
then
go.
click right here,
Is that right?
display settings.
Because mine's gone to a full screen and I can't
Yeah,
see
Yeah,
anything
do you
else.
see
see
that where I
this?
circled display settings up here?
It's this.
Oh, we're out again. You have to
Yeah.
stay in the display in the presentation mode, Gordon.
Yep. Am I in it now?
Yes.
If you're looking at two screens, don't look at the screen that has all the other, that is just your presentation. Look at the one that has your next slide visible.
Oh,
Right there at the top where Jesse is, I believe it was Jesse, has indicated the display settings.
right. So I'm going to have to get my, I probably should make sure that I have it on a separate screen. Let me just look here where I am. My Zoom. Oh, I think I need to move the Zoom across to the
Gordon,
other
if
side.
you don't have notes in your presentation, you can use the version that we're seeing. That's okay. If you do have notes, just know we'll see them.
No, I don't have any notes.
Yeah, you could just go ahead and start the presentation.
You can also use the presentation mode and just move the other part over. You can adjust the size.
Right. So if I go to that now,
Yep.
is that, and do I need to make it? See, the trouble is when it comes up on my screen now, all I can see is just the presentation.
Okay. Well, I think we should just get going anyway,
Yeah.
Gordon. It's okay.
Yep. So you can see a reasonable, I'll go to the beginning.
Yes.
Yep, we can see it.
Yep. Good. Well, anyway, what I wanted to do this time is to give a bit of an overview of sort of context of substance use and overdose in West Virginia. Particularly, I think it's important because to try and bring out how some of the issues in West Virginia are very different to some of the issues in urban Baltimore, which I also know very well. I actually come myself from a small little country town of about 3,000 people. But in New Zealand, where my dad was a country doctor, so I sort of do understand some of the issues of small country life. But it was a real eye-opener when I came to West Virginia to see the small towns in West Virginia. And they were much more like some of the third world countries that I've worked in some of my other studies. So really, it is a fascinating place to work. And what I'm trying to do with this presentation is to give people some idea about the background and some of the issues that they might be interested in looking at and following up with me. And I should also mention that this is really on behalf of multiple collaborators. And I, a bit like Sean, can't give a whole overview of everything that's going on in WVU. So welcome to West Virginia, and it really is wild and wonderful. And just to put it in background, I think it's important that West Virginia is really a public health laboratory. It is such an opportunity to look at everything, not just opioid overdoses, but almost any public health problem. It's got the highest rates for heart disease, cancer, obesity, diabetes, has the highest smoking rate in the country, high rates of some mental health conditions, and also drug overdoses, the highest rate nationally. But the fascinating thing to me is prior to 2000, our rates were lower than the national average by quite a lot. And also what's kind of interesting, just to be more of the good news piece, currently West Virginia has the highest decline in fatalities in any of the projections that CDC is doing now with their drug overdoses. So just to put a thing about how this drug problem evolved quite differently in West Virginia. So this is looking at the trends in drug poisoning. I'm always interested in the historical development of these things. And up until 1999, the drug overdose fatality rates, which were using the same criteria as unintentional poisonings, were lower and quite a lot lower than the US. And if you were to blow that section up, you do see some funny peaks in here, funny drops here. They're not real drops. They're just troubles with reporting. They were a bit late those years because they got overwhelmed with the number of drug overdose fatalities, and the medical examiner couldn't get the statistics into the system in time to be able to do it. But basically, you're seeing this catabolic increase, which is actually occurring much faster than the US as a whole. On contrast, I think Maryland has had a long-term urban drug problem even back when I was living in Baltimore. This is just showing the Maryland rate compared to the US. And as you can see there, the Maryland rate was higher, but it's largely been driven by the Baltimore urban drug problem. And as you can see here, I don't know whether my pointer is showing there, that even back in 1993, they had a significant drug overdose fatality rate. So how did West Virginia come to get the highest overdose fatality rate in the country? Prior to 2000, the unintentional poisoning rates, as I mentioned, were well below the US average, and now we're much higher than any other state, and it's 2.5 times higher. And how do we create the problem in West Virginia? There largely is an issue of the high prescription rates for prescription opioids, including OxyContin. We all know the Purdue Pharma and the whole overprescribing of opioids. But West Virginia was particularly targeted because we had a high rate of people with disabilities, a high rate of manual labor, and there were very active efforts to target West Virginia as a great new market for these wonderful new opioids that would solve all the pain problems that people were having. So this is just a little quick infographic that I came across, just showing huge, down in the southern part of West Virginia, huge prescriptions per population. It's just unbelievable how much was actually prescribed. And this is part of some work that one of my doctoral students did, some very interesting looking at trends. This is showing the MMEs per capita of opioids over time. 2005, this huge peak and ending in about 2010. And the other part that I think is part of the problem in West Virginia, they recognized very early that they had a problem on their hands. And actually, the decline in prescriptions for opioids occurred much more in West Virginia than in many other places. And I think that the trouble is the state did not have the capacity in how to respond to this. And then coming from the big cities, which had the traditional drug problem, they obviously supplied the market. And then we developed this rural drug problem. And this is the rate of the prescription opioids. And then this is, you can see fentanyl. So what was happening was as the prescriptions were going down, the heroin was going up. But then along came fentanyl. And as we know, that just changed the whole dynamic. Drug overdose. This is some interesting old slide that I was able to find looking at the county, how the whole drug overdose problem changed by county in West Virginia. And way back in 1999, there were high rates just down in, this is very much in McDowell County, which is the sort of one of the centers of coal mining areas. And then it expanded and expanded out, and now the whole area around the southern part of the state. So it's not a statewide problem, it's a very localized problem, but we're talking of rural towns rather than a local problem in Maryland, which was a big city of Baltimore. And this is just showing the current state using some of the more recent pooled data. And it's still very much a problem in the southern counties, but there's also some now up in the eastern panhandle and the other panhandle. So first off, as part of my interest, I'd had a long history of working with medical examiner data when I was in Maryland. I actually developed the first computerized database of the Maryland medical examiner system when I was working at Hopkins many, many years ago. So one of the real strengths of working in West Virginia is that we're one of only 17 states with a fully centralized statewide medical examiner system. And it's very comprehensive and has been in existence a long time. And Maryland also has a very good system, as many people use the data from the Maryland Medical Examiner. One of my colleagues, Maria Bate, created this forensic research data set going way back to 2015. And the purpose of it was actually to look at drug interactions, because often the drug level of a single drug was not enough to kill someone, but two drugs combined was a whole different issue. We pay, in fact, my endowed chair now funds this abstraction, continue this from the medical examiner's office. It has toxicological testing of all cases. They do a screen and then they do confirmatory tests. And one of the unique things of this is that we have drug concentrations, which is a very important piece of the whole problem. This is just a very simple, I'm not going to go through this in detail. This is just showing some of the results of our data and the number of cases each year. And this here is the fentanyl analogs that everybody knows about. But as you know, in West Virginia and many other places, it's not just a single drug that's involved in killing these folks. We'll often find many other drugs involved at the same time. So we did a series of multiple studies involving multiple drugs and looking at their interactions. The key part was having the drug concentrations. And there was an interesting paper that some folks at NIDA were involved publishing, talking about sex differences or metabolism. And we did an interesting paper showing that it was really related to the very difference in the drugs that people were using, and particularly co-involvement of alcohol, which is another respiratory depressant. But this slide here that I'm showing now is an interesting, there have been some suggestion that buprenorphine, if it was present, you actually could be protective for a drug overdose, even with an acute exposure of fentanyl. And what we were able to do is to compare the fentanyl concentrations and the buprenorphine concentrations in all of the fatalities. And essentially what we found, this is the fentanyl with no buprenorphine, and that as you got more buprenorphine, you needed a higher concentration of fentanyl to be in the death data set. And also another interesting factor is that if you had free buprenorphine, it was much more protective than if you had the metabolite. In other words, much of it had been metabolized by the bloodstream. So then another part of the puzzle is what drugs are people actually injecting. So we're looking at we earlier showed what people are dying from. And there was an interesting group that approached me about the idea of could we examine drugs in syringes to look at what the syringes were people were using. Also, the medical examiner data often takes 3, 4, 5, 6 months to come back because they get backlogged. And could we develop a more real-time system? And we were very fortunate to get some funding from the Office of Drug Control Policy to do a pilot study where we would collect the syringes from the 6 syringe services programs, and then they washed them out with a bit of methanol. We would then analyze the samples, and it didn't go through all the expense of doing concentration, but we were just looking at drugs present. And so we basically were successful in getting over 5,000 syringes tested. 97% were positive for at least one of the drugs in there tested. The significant part to me was that there was multiple drugs in each syringe. Very few syringes had just single drugs in them. We found up to 51 different drugs, and some interesting things. We were able, the local community involved where there was the syringe service program were very supportive of us, but the state didn't have that funding stream ran out. And unfortunately, the program has ended and we're still trying to seek funding. But one interesting thing is when we look at our fatalities, almost 100% of them involve fentanyl nowadays. Even with the high meth rate in the state, the fatalities tend to involve fentanyl. And among the syringes, there was only less than 80% of them had fentanyl in them. So the suggestion is that it's the fentanyl that's the largely part for the fatalities. And that's particularly been shown in some of the more recent studies looking at the whole evolution and the decline in drugs in the country. We were also interested in being able to pick up the emergence of xylazine. It just so happened at the time that xylazine was being introduced into West Virginia. So that's another part of the puzzle. But the interesting thing is, I started looking at the National Center for Health, National Survey of Drug Use and Health data, and whenever any of the tables, any of the reports I could find on state-specific data, West Virginia had lower usage rates reported in national surveys than the national average. And this sort of got me puzzled. And I was fortunate to be able to put one of my doctoral students, Chrissy Donahue, to look at this. And she's looking in detail at the actual self-reported data from the drug use trends in West Virginia, and it is consistently low. And this is the figure here. This is West Virginia and the US consistently reporting whether we used all illicit drug use or whether we changed to illicit drug use other than cannabis or marijuana. And the only significant increase in reported use in West Virginia was that for methamphetamine. So the interesting thing is that these usage survey data doesn't explain the high fatality rates that we get. And is it that we have really high, which is my theory, very high case fatality rates among the users in West Virginia? Or is there a systematic underreporting in West Virginia compared to other places, which I find we could not find any evidence for this? And so I think the big issue is it's not just an issue of drug use, it's that we have a very high fatality rate. And that's something that I'm particularly interested in exploring, looking at. So we actually need better data on drug use in the community rather than just fatality counts. And how can we measure drug use in communities like this? I've been interested for a long time in measuring drugs in the wastewater. In fact, in New Zealand and Australia, it's part of the national sort of community drug control program. They have been assessing sewage in the wastewater for many years, and I've visited and worked with them a number of times. And in fact, in New Zealand, 80% of the population are covered by measuring drug use in communities. And it's proven to be very interesting even to evaluate drug trends in communities and also the effectiveness of some community prevention programs. And I actually have written a proposal to NIH to look at this prior to COVID, and then along came COVID, and we were able to shift and pivot this model that we've been talking about. And we now have 31 sites all around the state where we monitor for all the respiratory diseases, and COVID as part of it. Expanded from COVID. We're now expanding into pertussis, bird flu, and a whole range of other things. And I've been trying for ages to get the time to put it into a study to look at it. And fortunately, we were able to build a collaboration with Hopkins. So basically, the drugs that people consume are excreted, or the metabolites. And many countries have this large program. There's some implementation in the US, but none in the rural communities. And we're currently developing a proposal. We put a proposal into the Bloomberg Health Initiative at Hopkins. And it's collaboration with Carsten Price and others, and Susan Sherman. And we hopefully will be able to get this off the ground. I just got a note recently that it looks like they are very interested in funding it. So this could be very interesting. And some of the uses of it is to be able to detect shifts in the illicit drug supply. And for example, how does community drug use relate to fatalities? Are there high rate counties that have a high fatality rate, but their drug use is lower, or on the other side of the coin, low fatality rates with high drug use? There's huge variation in overdose fatalities by county in West Virginia. And can we use this to try and better understand how effective the intervention strategies are? And the interesting thing is you can also measure naloxone in the wastewater. And so we're hoping to be able to even look at measures of community naloxone use. There's lots of data out there on how much is being given out in each community, but whether it's used is an important part. And that's why I think wastewater could provide some useful, interesting opportunities. So the big question is, why is West Virginia's overdose fatality rate so high? And to me, what we're working down in some of those communities that I showed you on the map earlier with the very high fatality rates in the southern counties. And we're collaborating with the Southern Highlands Regional Mental Health Center. And what we're doing is mapping the actual locations of where all of the fatalities are occurring. And they also have a program called Quick Response where they go out and investigate any of the overdoses where the EMS were involved and they were successful in reviving people. And we're now planning to map the location of those from the EMS. And I think a big part of it, many of these areas in the county, they're really remote, well away. You see a city here, a town here. These towns are really small. And the idea being that a lot of it is that the no EMS response. Some of these communities, they call up the ambulance and they say, well, on a fine day, we can be there in 25 minutes. But it's snowing like crazy right now, and it could be 45 minutes before we can get across the mountain to you. And as you know, that's not enough. That's much too long to be able to revive someone with the Narcan coming from the EMS service. And so part of the goal of this is to look at other means of getting community out into the naloxone out into the community. And for example, when they call the EMS and they say, okay, it's snowing outside, we'll be there in 45 minutes. But in the meantime, we have a list of 20 people in your community who have been trained in naloxone, and we will give them a call and we hope that we can get someone to you very soon. So that's part of the plan and what we're trying to do with this project down in the southern part of the state. So just to finish up, I see I'm just about at the right time. I think this wastewater will be a very interesting supplement to some of the work that we're and trying to understand the drug problem. But the key issue to me is and to get people interested in collaborating on projects is why is our fatality rate so high? Some of the other potential issues is that I think West Virginia has it's at the very end of the drug supply problem. It's very easy to get drugs into Baltimore, and you tend to get some increase in overdose when a new drug, such as these animal drugs, start coming in. But in West Virginia, the local distributor, the local dealer of the drugs is required to give someone a baggie every day or as often as they want and need it. And so the drug gets progressively diluted and diluted all the way through the supply chain. And as a result, but then sometimes there's a bit more fentanyl available to the dealers. And so I think we're getting a very variable drug supply. And that's another theory that I don't have the evidence for, but I would love to have the evidence to be able to do that. So that's just some of the comments I have. I really can't cover all of the work that's being done, but we've got an interesting department of epidemiology and biostatistics, and I look forward to developing collaborations with people.
Great. Thanks so much, Gordon, for sharing us a lot of your experience. So we're going to have some time, a little bit of time for some questions. Sean, you presented the proportions that was that drug testing when you said the proportion that were using heroin and fentanyl, or was that sort of the self-report of what they thought they were taking?
Now that was all self-reported data.
Do you have any of the testing based on some biological measures in urine or other?
Not yet. I'd love to dream up a proposal to do that though.
And Sean, related to that, what about the self-report? Like, do they really just say meth versus fentanyl versus heroin, or did they report multiple things?
Oh no, polysubstance use was the norm,
Yep.
and we published papers about polysubstance use,
Yeah.
and it's I would say the majority are polysubstance users.
Yeah, yeah. So, and Gordon, a lot of your work sort of emphasizes the polysubstance use, both in terms of overdose and fatality. Is it actually? I'm going to let others ask questions. I can always ask questions, but Renee, go ahead with your question.
Hello. Hi, Gordon. This is Renee Johnson.
Hi there. Good to see you again.
You too. I just wanted to say hello from the Injury Center. And I appreciated learning about your work. Hopefully this leads to many collaborations. One question I wanted to ask was, does the presence of cocaine versus meth in postmortem toxicology vary by county across West Virginia? And if you know that, how does it vary?
I actually don't know. We don't get a lot of cocaine in West Virginia. It's almost entirely methamphetamine as the stimulant.
Okay.
I can look at it, and it would be very simple to do. Um, what's the problem in Baltimore? Is it mainly cocaine, isn't it?
In Baltimore,
Historically,
it is
yeah.
more cocaine. But it becomes a little bit more meth. Sean Allen knows this better than I do. Uh, in Maryland, near the West Virginia border. So I was wondering if in West Virginia, is there more cocaine near the Maryland border?
Oh, I don't know. That would be interesting to look at. I'll take a look because very clearly the drug supply in the Eastern Panhandle is coming from coming from your area, up from, and whereas in the other parts it's coming from Chicago and a whole bunch of other places in Detroit.
Interesting. Yeah, in Baltimore City, historically it's been very, very little methamphetamine, but in recent years we've seen an uptick in that. It's certainly been dominated by cocaine historically. Gordon, my question was going to focus on not the types of drugs used, but the modality of use. And if you think that may be contributing, you're looking at the tox identification of the drugs, but it's unclear if that was by injecting or by other forms of use. And Sean, I think this relates to your work as well. You're focusing on people who are injecting, but there's thoughts that smoking or other methods of use may reduce your overdose risk. Do you guys have any thoughts about modality of use rather than the specific drugs and how that
Yeah, I've been particularly
overdose?
interested in looking at the modality, and we have a variable in our medical examiner database on the modality, but there's a large amount missing, which is the
Of
problem,
course.
is that they don't get that. And but certainly anecdotally, we start hearing that people have been smoking a lot more recently, and some of the theories are that's part of the reason for this fairly rapid decline in drug use. But I don't know, and I think the best way is to get at it from sort of survey data as a way of approaching it.
Yeah, I can share some data from our existing cohort. Let me share my screen. Um, so these are data that we asked people about each substance that they had injected or used, and then we asked, did you snort it, inject it, smoke it, or ingest it? So you can see there's some pretty substantial differences here, but not surprisingly, crystal methamphetamine is sort of the main drug right now, at least in Cabell County. And most people are injecting it. But we do, with our cohort, we will be able to analyze shifts in how people are using. So recently, in December of 2025, the harm reduction program closed. So we do expect to see some shifts away from injection toward smoking or ingesting drugs, but those analyses are ongoing.
And any signal in terms of overdose since the closure of the harm reduction services?
Analyses are ongoing. I don't know.
Okay. Let's open it up. Are there other questions is there any other questions from the participants?
Lauren Saplicki, you dropped something in the chat. Do you want to come off mute and just ask?
Well, that's about the grant. Lauren, in terms of the grant opportunities, I think that it's open. There's no restriction on what constitutes substance use. Substance use is identified as a priority area, but it doesn't suggest that only priority areas will be funded. So I think it's really wide open with a few identifiable priority areas. There's another question, Gordon, from Jake. asking about higher fatality on the I-79 corridor, and again, referencing long EMS wait times.
Yeah, it's an interesting thing. I've seen some maps that some of my colleagues have done, mapping it to the major highways in the state, and there is certainly some relationship to that, but I don't know how much.
In most of these cases, as in with many public health problems, it's multidimensional and multifactorial, and it's probably a variety of contributors, both what's available, access to response services. Rushi, you have a question?
Uh, w- Well, this is responding to your point about the modality of overdose. I do not know about the overdose, but we created a database of infective endocarditis in the state, West Virginia, using electronic health records. And what we found is about 70% of the people were injecting drugs. So I think you are right on track on that point that probably mode also contributes to high overdose.
And both Gordon and Sean, thank you for that clarification. Um, are you also seeing other comorbidities related to drug use, such as the xylazine or other related wound infections? Has there been signal related to that in West Virginia as far as anyone knows?
Yeah, so we're
The
tracking
one,
that in our cohort study, and we are seeing a lot of reports of wounds.
yeah, and I think it in some areas, certainly we're hearing that from some of when we're doing the study with the syringes, it was just beginning to be a problem. I think that one of the issues is in West Virginia, things tend to occur later than in many other places.
Well, that's been historically the the in Baltimore, we've often, had entry relatively soon, but responses and treatment options filtering in slower. Maybe not true for
Exactly.
some harm reduction services.
And,
Other
and that's
questions?
certainly become a big concern. Up until relatively recently, we didn't have much of an HIV problem in West Virginia. And as you know, we've had a big problem in Baltimore for many, many, many years. But now, as a result of the closing down of many of the syringe services programs and other issues, there seems to have been a dramatic increase in rural areas, and it's still something we don't even know about.
If there are no other questions, I want to thank both Sean and Gordon for sharing their experiences and expertise. I think it illustrates the substantive amount of research and activity that's ongoing, particularly related to substance use. There's certainly a lot of substance use related research and practice in Baltimore and Maryland from our institution. These collaborative proposals emphasize the interest in comparing urban and rural. I think there's probably bidirectional learning that could be facilitated through our collaborative efforts. Um, so with that, again, thanks to Sean and Gordon for sharing your data and your experiences with us.